We're going to open the floor for questions and answer. And while we're going to be asking the presenters to come to the stage.
Thank you. John, go ahead. And we'd be very grateful everyone could identify themselves and give the name of their institution.
This is Mona Sarai from CDC. I have a question for VIA, for Raúl or José. My question is, I don't think the issue of VIA is resolved. And I just wanted to understand, in terms of using VIA in low and middle income countries, there just seems to be still substantial debate about using VIA when there is nothing. I've heard people say, I would never use VIA in low and middle income country settings versus HPV testing. And I was wondering if you can comment on that and what you think needs to be done to put that debate to rest.
I think it's an excellent question because it's something that we hear and we discuss extensively every time we talk about what to do first. Oh, I have not that much money. Where should I put my money? Actually, that was a question I got recently in one meeting. Our experience and data from our study that Raúl presented show that one of the sites where we implemented HPV testing, all the tests were not performing that well. And the difference between that site and the others that did a very well job and good result with HPV testing was the capacity, experience they have for pelvic evaluation, all the implementation of the cervical cancer activities. If you are going to implement HPV testing, you need some basic level of experience in the ground to do the evaluation of the HPV positive. Otherwise, you're going to have a huge problem because there's going to be no way to solve the problem to those who are HPV positive. If you want to start a program, obviously, I don't want to go with pap smear because we know what happened with that. If we have visual inspection and HPV testing, I will start with visual inspection before going to HPV testing. Create capacity there for pelvic evaluation. It's not that easy for many providers to learn how to do pelvic evaluation. A basic training how to evaluate the cervix with a vinegar and see if there is a cancer or not. We don't know providers to miss those cases. And capacity to treat those who have pre-cancer. And after you have that capacity, you are ready to start with HPV testing. That's my opinion.
Well, what I would say is that we need to think about which is the objective of introducing VIA or any new technology, because it is related with the problem we want to solve. We introduced VIA in our country because there are several regions where access to regular care is very low. So even having an 100 sensitive test for cancer screening, cervical cancer screening, won't solve the problem because the problem is that women are not going anywhere after having a screening test. So the reason we introduced VIA is because it provides immediate results and it allows us to provide immediate treatment as well. What reduces cervical cancers is not early diagnosis, but early treatment. And it is obvious, but I think that it's not useful in our minds. We think that we need a perfect diagnosis, even though we don't have the treatment for the women. So I think that if we need in that way, maybe we can think in a better way, how can we apply these new technologies? Of course, we have results from rapid HPV test. That would be wonderful for us. But there are several things that we need to solve before implementing even those technologies in our countries.
I guess I would just add the one thing that I think we have definitive data from India showing a drop in mortality. We don't have that for many other things. And I think that people, the recent reflections for the WHO guideline revisions really suggest, after a very careful review of the evidence, that VIA is a viable and valuable technique to add to the arsenal. So I think that perhaps when the WHO endorsement of it through that is out, that will be a more helpful way for those who have heard many questions and not really had a chance to review all the evidence.
Thank you. Next question.
Silvia Silvia San Jose from the Catalan Institute of Oncology in Spain.
Louder. Silvia.
Louder? Okay. So I just wanted to follow Raúl's presentation, which it was very interesting and very inspiring. You mentioned this resistance to use HPV test, and our experience in Spain, which is not a developing, but maybe we will fall into developing very soon, is that people like HPV, but they don't give up pap smear. So we increase our activity and higher costs. So that's very difficult to enter into a more programmatic organization of use what is more appropriate. But my question was, have you ever evaluated how many pap smears have been taken and never follow up? Because I think I have heard from some of our colleagues that this happens. No, we have a coverage, but then there is not a real diagnosis of that cytology, and that could be one issue. And the other point that I would like to raise is that the variability that you show, that based on the work done by Dr. Jerónimo, on visual inspection, this variability may not be such if you use HPV testing. And there are some tools for HPV testing that they are very robust and very stable. And our experience is that in the different levels of technology preparation in the laboratories, people perform very well HPV diagnosis. So probably our future goes into robust, automatized technology that can be implemented in low-resource settings.
Yep, we have evaluated the percentage of women that have been followed up after a positive pap smear in our country, and there are not very much evaluation in Latin America actually. But we recently published a paper showing that in some of the regions in Colombia, more than 40% of women having a positive and aged high-grade squamous intraepithelial lesion don't go anywhere. So you have a test with a sensitivity of 50% and losing 40% of those who are positive, you're doing nothing. So that's a big problem in our countries. And I think that of course, as I presented in the figure with the data that Jose provided to me, I showed that the HPV tests are more consistent. They have more consistent results. They're more close in the space in the figure. But we have also big variations between countries for molecular tests as well. And that's what Jose was mentioning just a moment before, that even molecular tests could vary a lot between settings if we don't have a proper program around them. That's very relevant, I think.
But you didn't mention which type of test. So not entering into names of the.
Yeah.
But
yeah, they were. The shapes were representing the type of test, and they were all the tests. So we had the carrier HPV cervical samples, the carrier HPV vaginal samples. We have VIA, and we have pap smear there. And the colors were representing the countries. And even for molecular tests, for the carrier HPV, the variation was big for countries. They obtained more consistent results between countries, but they had also relevant variations between countries as well. It represents that it is not only the test, but the program around the test is very important to obtain consistent results.
Thank you.
Of course, it is lower for molecular tests than for VIA or pap smear.
Yeah, the experience from the TATI project, before the TATI project started in Peru more than 10 years ago, there was a study about how many women with a positive pap smear reached additional evaluation and treatment. It was around 25% only, I think.
Elisabeth Feidepas, Karolinska Institutet, and my question is to Dr. Jerónimo. After a HPV positive test or a VIA positive test, what to do? And I'm addressing the question specifically for Cambodia, which I'm helping the Ministry of Health to plan their program now. And we are facing that dilemma. Could you please comment?
Yeah, well, it's not an easy question. There are several groups working on that specifically. there are experiences showing that if we send all the HPV positive to colposcopy, even in countries like Mexico that had a good experience with HPV testing, sending those to colposcopy creates a huge problem in the system with delays. There is no Mexico has a big capacity for colposcopy, but even with that, was a problem to do the evaluation of the HPV positive. And also HPV, because of course you need to see what happened in the cervix. There is this issue of should we treat all of them as we do with visual inspection, for example? That's the big discussion now. In our study, because it was a study and we needed to prove disease, we did colposcopy and biopsy. But even within the study, it was not easy to call the patient for colposcopy and complete the whole process for biopsy. WHO is developing some guidelines, and there are some options in there that are presented as alternative. One of them is HPV. In those who are HPV positive, one option could be to do visual inspection in them, only in those who are HPV positive. The advantage is that if you already have visual inspection in place, if you add HPV testing, for example, with self-sampling, your capacity, you are multiplying your capacity for 5 times or 6 times because you are narrowing your evaluation to those who are HPV positive. That could be one option, but even with that, we need to be careful because if we attach to the visual inspection criteria we are using now, that means very clear lesions, clear border, and that description of positive, we could be missing cases with the second test, in this case, visual inspection.
I'm afraid of being redundant what I'm saying before, but again, that's relevant to think about the purpose of the strategy. If we're introducing rapid HPV testing with the purpose of improving follow-up of women because we can shorten the period between screening and treatment, we have to think exactly what we are asking. What would we do with the positive HPV women? Because if we want to do it in one visit, we need to use something as a triage to solve the problem in one visit as well, or in 2 visits as well. So bringing women back to the pap smear won't solve that problem of follow-up.
Hi, Jessica Sullivan with BSI. Did any of the HPV vaccine programs have an incentive scheme?
I'm sorry, did you say incentive scheme?
Yes.
No, we didn't pay anybody to get vaccinated, if that's what you mean by incentive.
I just was curious. I haven't seen that come up, and there's great adherence rates, but I was wondering if there was something I was missing.
No, I think from our experience, the adherence in terms of the minimizing loss to follow-up was really around the organization of the program and providing concrete opportunities for follow-up doses and follow-up missed doses, as well as doing good community education in advance of each of the doses to remind people basically that it's time now for the next dose. I don't know if Joseph has more to say on that.
Hi, my name is Megan Weissong Harris, and I work for JPIGO, primarily on monitoring and evaluation of cervical cancer programs. And I appreciate all of the presentations, and specifically, Vivien, you mentioned monitoring as a component in terms of scaling up. And I just wanted to present this back to the panel. Can you talk a little bit about your experience? Typically in a demonstration or pilot project, you collect a lot of data, but in terms of scaling up, often it's not currently in an HMIS system or a DHIS system, and how do you make that transition? And did your projects look at that and try to overcome some of those barriers?
Thanks for the question. I think it is really important on monitoring. I think on the vaccine side, it's actually much easier because, as Scott and Joseph described, this fits into a regular immunization program. They had to make new cards for girls, but they're used to making cards, and they did that. They know to make a system that'll track all 3 doses. And WHO has also set standards to add this into the joint reporting form, which is the form by which countries report their immunization data to WHO. And so they do it by age, by year of age and number of doses administered. So I think for the immunization side, it has been incorporated into routine monitoring. I think on the screening side, it's been more challenging. Health information systems are already very crowded. And every time you want to add something additional to it, it takes a very careful discussion and negotiation and time, because often those systems aren't changed maybe once in 5 years. So I think that's been an ongoing issue for all of us working in screening, and there's been focus around basically 3 main indicators and trying to get those into health systems. The number of women who've been screened, the number who are screened positive, so number of women screened as a measure of coverage, the number of screened positive as a sort of measure of quality, and the number of women treated as a measure of completion of care. And we've all sort of focused on those 3 indicators, but it's a slow process country by country to get those integrated into the monitoring and information systems.
I think I'll add just one point to that, and that is the individual-based record keeping for vaccination versus an aggregate reporting system. What Vivien's alluding to is an aggregate reporting system, which is common for immunization programs. This is not like the Australian, where you have a HPV vaccination register. Everybody gets a unique number, and it's subsequently in the future linked with other health records like STD clinic visits, hospitalizations, cancer registries, screening programs, etc. Most low resource settings will not have the capacity to do an individual record level assessment for each vaccinee. So it is aggregate reporting, but it is the start, and it gives them a foundation to think about those issues in the future. One thing that has been happening on the registry side or screening side is people have been changing their screening forms to add a question, did you receive the vaccine or not? And if so, how many doses? So you can, now we're not gonna see the advantages of that for years to come, because these girls who are vaccinated now won't be screened for another 10 or so years. But at least countries are starting to think about those linkages. But in the first instance, we need to clarify that it's just summary totals for coverage. Yeah.
Hi there, I'm Christina Parsons-Perez with the American Cancer Society. This morning we've heard a lot about information, education of community, and that community support for cervical cancer screening or for vaccines. From a civil society perspective, cervical cancer kind of fits, we have the cancer groups, we have women's health groups, sexual reproductive health groups, and if we're talking about the vaccine, suddenly we have this whole new layer of, adolescent health, child health. In your experience, so from where you stand as, government representative and implementers, where have you seen the leadership on this issue reside from the civil society perspective? And secondly, have you seen any successful kind of examples and models of these diverse groups actually working together? Thanks.
Who wants to start? Well, we've seen great examples of where there's been good leadership, and what's interesting is the horse driving the cart or the cart driving the horse on this issue? On vaccination, what's been fascinating for me to observe is in the first instance, it really is the cancer prevention people, women's health, reproductive health advocates that were driving the immunization people to think about vaccination. And that's starting to come around, but I think, at the beginning, the strongest leadership has been from cancer prevention side of things, reproductive health, adolescent health, and bringing them to the table. But the models that are working are the ones that, in fact, that Gavi is now requiring for people applying for HPV vaccine. They have to have a national technical advisory group that actually has all of those representatives around the table. And it's been fascinating to watch countries go through the process of building that stakeholder coalition. But once it's there, it's actually quite strong. It needs leadership from whatever sector to keep it functioning, and it could be immunization leadership, it could be reproductive health leadership, etc. But if there is a strong leader, that group has been, my experience and my observation, not just with our pilot programs, with other countries we're now working with on their Gavi programs, has been the leadership is key to that group being very, very highly functional.
Joseph? Yes, indeed, there has been also new actors, like in the school model program, you had the Ministry of Education, you have the people involved in education who really kind of took leadership out of it, and the other, which is more traditional for vaccine, but it's more important for girls is the community leaders. I mean, in some of the programs you had religious leaders sensitized and influencing the community to get better pickup of vaccines. And this is where we will need multiple parties getting around the table and to make it successful. So
I guess I would just add briefly that this has been referencing more the vaccination, but on the screening side, the leadership over the last decades has really come from the OBGYN societies, the medical societies, who care for women and who've lived with this problem for so long, and that's been the traditional place of leadership. And it's actually been a little bit of a challenge to get them to join in with the immunization and recognize that there are additional strategies now for this long battle that they've been waging. I think they will be happy to have allies in the battle, but it may take a little bit of time.
Yeah, just to add to that experience, the big opposition we found from some doctors, key opinion leaders, was from those who were not educated in these new technologies. And because they didn't know that visual inspection or HPV testing, they were not familiar with that, they just oppose. As soon as you involve and educate them, change completely the way they approach to these new technologies.
Okay, I'm Yuning Qiao from Cancer Institute, Chinese Academy of Medical Sciences in Beijing, China. So I have a question to Joseph Saba. You talk about the HPV vaccine donation programs. I remember in year 2009 when they made an announcement in New York, that's the Clinton Health Initiative, right? That is vaccination and the screening, the both, right? Both company, Merck and Kaijin, they offer the comprehensive cervical cancer and prevention. In your program, do you have any screening components, or in the future you can do more better, and not just the vaccination, and also including the
yes, that's thank you, Yulin. In fact, when the Garda's Laxis program started, it was really only related to vaccine. However, there has been the announcement of Merck and Kaijin getting together to help also in more comprehensive approach. I understand there has been some, but to put in place, it takes probably longer to put in place because there are many aspects. So I understand there has been in Rwanda and in Bhutan, these would be the two countries that have taken off with these two comprehensive approaches. Right. Most of the others were related to HPV vaccine. But ultimately, this is where we want to go. It just sometimes, you could start with one and the other and then put them together. Otherwise, it may take a long time.
Okay, thank you.
One more.
I think I just want to add to that is that it's not necessarily the case when we're talking about comprehensive approach that you're delivering the services at the same time. That's a sort of a different concept, and in fact, a very difficult one to implement because a screening test takes way longer than vaccinating a girl. You can probably vaccinate 100 girls in the time it takes you to screen a woman. So it's important that when we think about this comprehensive approach, it's simultaneous planning going on and coordinated efforts, but it may not be direct service delivery that's integrated. I know there's a pilot in Thailand and Philippines being done by Japaigo, doing joint delivery. We haven't seen the results because they're still enrolling, and we'll get some of those. But our experience in Peru has been that the invitation of the vaccination provides an opportunity to invite women to get screened, but the sectors in the health system, the screening is done by different nurses than who do the vaccination, so the scheduling of those activities needs to be quite carefully considered.
Hello, I'm Lucrecia Peinado from UICC, and my question is related to the comment you just made, Scott. It's like, if now with this learning, what are the advice to the organizers of the introduction of the vaccine to be able to respond to any increase in demand of screening given that mothers are informed, then that of course will get the ball rolling and they will be interested, mothers and caretakers of these adolescents. So if you have any lessons learned from this, like in Peru, and what will be the recommendations for the introduction of the vaccine in these new countries, how will they prepare, let's say, for that increased demand that comes with the community education and in the increased awareness of the vaccine? Thank you.
Yeah, it's a really good question, and I think the best way you can prepare is to recognize that that's going to happen. And all of the consultations we do with countries, we're very explicit with them that vaccine can and probably will generate demand for screening, which is why, as Vivien's pointed out, comprehensive planning is really going to be key, because you do have that mitigation against the demand for screening in absence of a screening program. So countries do need to be quite careful about how they message that and how they scale that up. And if they are going to go with vaccination in the first instance while they're still figuring out what to do with screening, they need to figure out ways to make sure that the community is educated and informed about that, so that you don't build resistance from the start for either of those initiatives. It's a delicate balance, but one that absolutely has to begin from the planning stages right in the first instance. I don't know if others have.
And I think we should just remember that we don't only increase the demand for screening, but there can be an impact then on treatment services and palliative care. And in terms of comprehensive cervical cancer control, those two areas in low-income settings have actually fallen a little bit behind, I think. I mean, there are some initiatives going on with various organizations to try and bring them up to speed. But the bottom line is that those two components are still, I think, pretty weak in many of these countries.
Hi, I'm Analia Stormer from CDC. We've noticed in our work in Bolivia in training nurses and physicians on VA and cryotherapy that there's a lot of resistance to training nurses on these technologies. I was wondering if you could comment on that and what have been your experiences and how would you deal with this issue? Thanks.
That's a very good point, because that resistance happens in many places. For example, in our experience in Tati project started 10 years ago, doctors opposed at the beginning for midwives to do visual inspection. But in real life, in practice, visual inspection had more skills than many doctors to do a pelvic evaluation and a good visual inspection. That happens, but we need to involve both groups. If you only train nurses or midwives and not doctors, that is even worse. You have to include both of them. I don't know how you handle the situation in Bolivia, but once they start to be trained, both groups, they don't feel that they are. They are part of the team, and in that way, we were very successful to train the midwives in Peru. Now, it's not only for visual inspection. Now the discussion in Peru, for example, is should we train midwives to do colposcopy? The phase to train them on visual inspection is over. They are trained on visual inspection. They are the first group doing visual inspection in the country. Now the question starts, should we give more to them? I mean, probably in a few years we will find more midwives doing. There are some doing colposcopy in Peru. I mean, it takes time, a lot of education, but keep working on that. Involve both groups, educate both groups, and it's going to start to change.
Our experience in Colombia was different. Well, we trained nurses for doing visual inspection, and it was well, I don't know if I can say allowed by the Colombian Society of Colposcopy, because they said that they preferred nurses to be trained than GPs, because they think GPs could become, in practice, some kind of gynecologist making some competition. So they say that we prefer nurses. But the other point is that we're implementing VIA only in specific regions, specifically allowed by the Ministry of Health. So we're not extending the program to the whole country, only specific regions that need access, better access to treatment. And the other fact is that I don't know if it changed the situation. The situation in Peru has changed, but the TATI project trained midwives, but the midwives' diagnosis was reassured by GPs. In my opinion, decreasing the sensitivity of VIA in that case also.
So we're almost down to our last 2 minutes. Just a comment to that one is that one of the things that we learned, and this was harped on by most of the presenters as well as by Vivien, is the fact that when you go into cervical cancer prevention or any other program, is that training is not the only tool that we have. We need to be able to have a strategy, a program around it, as well as the environment that actually creates a supportive situation for us to be able to carry what we are doing. So with that one, let me segue into the fact that we have the technology and we've seen how it works. We have learned a lot from different countries, both in Latin America as well as in Africa as well as in Asia. So that with this one, what I'd like to be asking everyone, including us, is the fact that let's seize the day and see what we can do for the women that actually could be saved through an effective, comprehensive cervical cancer prevention program. So before we end, I'd like to thank first and foremost the organizer for giving us the opportunity to actually have this discussion, our presenters who poured out their experience just to share lessons that they have gathered from implementing their projects. And lastly, for your patients to come here very early, stay on with us, and be engaged in moving forward with women's health. Thank you so much.